Hello everyone, welcome to day 6 in genetics. Today we are going to discuss about some of the disorders which are associated with defects in structural proteins. So, the two important conditions or two important disorders which are associated with defects in structural proteins are: one is Marfan syndrome, another one is Ehlers-Danlos syndrome. Both these syndromes are extremely very important. You can get lot of MCQs from the PG entrance exam perspective as well as for your prof exam. This is one of the most commonly asked short note question: Marfan syndrome and a Ehlers-Danlos syndrome. In this session, I am going to discuss only about Marfan syndrome, the Ehlers-Danlos in the next one. First, remember what is this Marfan syndrome? Actually, it is a disorder of structural proteins. Structural proteins means connective tissue, and the clinical manifestation is mainly in the skeleton, eyes, and cardiovascular system. Remember, skeleton, eyes, and cardiovascular system. You have to remember these three systems when we discuss about, or when you write about the clinical manifestations. You have to write mainly about what are the changes it brings in skeletal system, eyes, as well as in the cardiovascular system. And remember the most important point, that is they are mainly autosomal dominant inheritance. Autosomal dominant inheritance, that is 70 to 85% are familial and the rest cases are sporadic. They may arise from new mutations. So remember, coming into the pathogenesis, what is the defect here? Here, the Marfan syndrome results from an inherited defect in an extracellular glycoprotein which we call it as fibrillin 1. This is one of the most common mistakes students commit. They will think that Marfan syndrome is due to some defect in collagen. No, it is fibrillin 1. Okay, yes. So whenever this, actually what is this, what happens when this there is a loss of fibrillin? See, whenever there is a loss of fibrillin, there will be loss of structural support in the microfibril rich connective tissue. See, fibrillin, fibrillin, lamin, all these are, then we have fibronectin, all these are the components of what our extracellular matrix, am I right? Connective tissue, basement membrane, everything. So whenever there is a loss of this, there will be excessive activation of TGF beta. Excessive activation of TGF beta. Okay, so this is the simple mechanism. So whenever there is a loss of structural support, okay, so the clinical manifestations may be due to two reasons. Number one is due to the loss of structural support because the fibrillin 1 is mutated, and the number two is because of excessive activation of transforming growth factor beta. Fine. Now let us see each of these manifestations. So fibrillin, remember this fibrillin, they are mainly present in aorta, in the ligaments of the joints, ciliary sonules, okay, that support the lens. Okay, so these three tissues will be most commonly associated in or affected in Marfan syndrome. Remember, we have two fibrillin. This is one of the most commonly asked question. This question has been asked already in AIMS. Okay, that is what is the chromosome number. Remember, fibrillin is encoded by two genes. One is fibrillin 1 and another one is fibrillin 2. Okay, and remember, fibrillin 1 is 15q. Okay, fibrillin 1, I am writing here, fibrillin 1 is due to chromosome 15q. Okay, there, don't worry, if you can remember 21.1, but that's not needed. Remember 15q. Okay, whereas fibrillin 2 is coded by chromosome number 5q. Okay, please remember these 2 points. Fibrillin 1 is 15q chromosome and fibrillin 2 is chromosome number 5q. So out of this, they will give you a statement. Out of fibrillin 1 and 2, which mutations are more common? Remember, out of fibrillin 1 and 2, the mutations of fibrillin 1 is more than that of the mutations of fibrillin 2. So, when fibrillin 1 is undergoing mutated, it gives rise to Marfan syndrome. When fibrillin 2 gene is involved, they leads to congenital contractural arachnodactyly. I told you that the pathogenesis behind this condition is there will be loss of fibrillin, number one. Number two, transforming growth factor beta will be activated. You know that transforming growth factor beta is responsible for what? Fibroblast proliferation, am I right? And all. So, whenever there is excessive TGF beta activation, yes, what will happen? Like we have studied, no, what hypertrophic scar, everything. Yes, here we have congenital contractural arachnodactyly. Again, it is mainly characterized by skeletal abnormality. It is also an autosomal dominant disorder. Fine, autosomal dominant disorder. Okay, fine. Yes. Then, so that is the first mechanism. Second mechanism is transforming growth factor beta bioavailability. So remember, I told you that because of excessive transforming growth factor beta signaling, there will be what increased activity of metalloproteinases causing loss of extracellular matrix. Transforming growth factor beta, TGF beta, is going to activate MMP, matrix metalloproteinase. It will degrade the extracellular matrix, so there will be loss of this. Okay, yes, we have two sets of observations has been found out here. Okay, number one, whenever there is a gain of function mutation in TGF beta type 2 receptor, it will give rise to a related syndrome called Marfan syndrome type 2. So TGF beta type 2 is affected or mutated, what will happen? Marfan syndrome type 2 is there. Suppose there is another one isoform of TGF beta is there, that is called TGF beta 3. Okay, so if TGF beta type 2 is affected, Marfan syndrome type 2. If beta 3 is affected, what will happen? The patient will be most commonly presented with cardiovascular manifestation, that is aortic aneurysm. Remember, aortic aneurysm is one of the most deadly and fatal complication of Marfan syndrome. Okay, so this is the first observation. What is the second observation? Okay, in mouse it has been found that okay, angiotensin receptor 2 blockers, angiotensin receptor 2 blockers, they are going to inhibit the transforming growth factor beta activity, which will reduce the aortic root diameter in mouse models of Marfan syndrome. So currently what is the treatment modality they are trying? Angiotensin 2 receptor blockers has been tried, okay, in patients with the Marfan syndrome. Okay, that is it's under trial only. We have no evidence to support the use of angiotensin receptor 2 blockers in Marfan syndrome. So these are the two set of observation. Once this is done, let us go for the morphology. Remember three things. What are they? Cardiovascular, ocular, and skeletal. Out of this, skeletal is the most striking features, because when a patient comes immediately, it is the skeletal. His skeletal deformities will be what that we usually notice the most. Remember, the patient will be unusually tall, exceptionally long extremities, long tapering fingers. I told you that the ligaments and will be lax. Okay, remember the thumb can be hyperextended back to the wrist because of the laxity of the joint ligaments. Okay, it will be long-headed. The patient will be long-headed with the bossing of the frontal eminence, prominence of supraorbital ridge, and lot of spinal abnormalities like scoliosis, kyphosis, everything will be there. And it is a deeply depressed sternum, that is called pigeon breast deformity, also called as pectus excavatum. Okay, yes. Then ocular form, remember there will be dislocation of lens, usually outwards and upwards. How I used to remember is in Marfan syndrome, see, fan is always up, so the dislocation of lens will be upwards. Okay, you can remember outwards and upwards, or generally upwards, because we have another condition called homocystinuria where the dislocation of lens will be down. How I used to remember? Urine always goes down, so the lens will be dislocated downwards. Fine, yes. So that is Marfan syndrome. Here I told you because what? Weakening of the ciliary zonules. This is called ectopia lentis. Dislocation of the lens is what we call as ectopia lentis. Homocystinuria, I think you have read in biochemistry. In that also you will have ectopia lentis, but that is downwards. Okay. Then the most life-threatening feature of is cardiovascular. And here comes the question: what are the most common lesions? What are the most common lesions? Number one is mitral valve prolapse. Okay, number one is mitral valve prolapse. Okay, and number two is dilation of the ascending aorta due to cystic medionecrosis. And what are the changes? What are the histological changes? There is not that much important for an undergraduate to remember what are the histological changes. Just remember one word: cystic medionecrosis. Okay, yes, fine. Next, another most important thing is there will be aortic dissection. See, because of the weakening of the tunica media, what will happen? The tunica intima will undergo tear very fast, so which will produce some intramural hematoma, and this is responsible for aortic dissection. Just remember, weakening of the tunica media. That word is important. It is the weakening of the tunica media which predisposes to tunica intimal tear, leads to accumulation of blood within the blood vessel walls, and that is responsible for what we call as aortic aortic, which will cleaves the layers of the tunica media. So here the pathogenesis is with the what? Tunica media, not intima. Very, very important. It is the weakening of media which is responsible for all this. Okay, not intima, leads to aortic dissection. And I told you aortic aneurysm and aortic dissection both are life-threatening complication. Out of that, aortic dissection is the cause of death in Marfan syndrome. Okay, aortic dissection is the cause of death in Marfan syndrome. See, the great majority of deaths are caused by rupture of aortic dissection. Okay, of course, mitral valve prolapse. Okay, we call it as what we call it as a floppy valve. Okay, floppy valve. Why the mitral valve is prolapsing? Because of the loss of connective tissue support in the mitral valve leaflets. What will happen? The valve will becomes soft and billowy. Okay, that is responsible for the floppy valve. Okay, yes. And another most important is a single just a one-liner. How will you make the diagnosis? The clinical diagnosis of Marfan syndrome is currently based on what we call as revised Gen criteria. What is the name? Just remember, you should not know in detail about the criteria. Just remember revised Ghent criteria. Revised Ghent criteria, and it will take into account the family history, cardinal clinical signs in absence of family history or fibrillin mutation. And I have already told you what are the 4 organ systems mainly involved: skeletal, cardiovascular, ocular, and skin. Out of that, skeletal, cardiovascular, ocular is important. Out of that, most life-threatening is cardiovascular. In cardiovascular, what is the most common? Aortic aneurysm. What is the most fatal? Aortic dissection. Okay, so these are the most important points you have to remember in Marfan syndrome. So with this, we have finished Marfan syndrome. Please remember Marfan syndrome autosomal dominant. Fibrillin 1, chromosome 15. Fibrillin 2, chromosome number 5. Fibrillin 1 undergo mutation, Marfan syndrome. Fibrillin 2, congenital contractural arachnodactyly. Then remember, skeletal abnormalities are the most striking feature. And what is the criteria we use for the diagnosis of Marfan syndrome? It is called the revised Ghent criteria. Okay, remember what the 2 important pathogens is behind it. One is loss of fibrillin, and number 2 is excessive activation of transforming growth factor beta. Okay, and in cardiovascular we have mitral valve prolapse, and next one is dilation of the ascending aorta due to cystic medionecrosis. So in the option, if you see cystic medionecrosis, you can definitely go, it is histological features of Marfan syndrome. Then what is the cause of aortic dissection? It is because of the tunica media weakening and not due to tunica intima. Okay, yes. So with this, we have finished Marfan syndrome. Thank you.